right, Zoe, do you want to go ahead and introduce Maureen?
Yes, thank you, Becky. Well, welcome everybody to today's webinar, Act Now, review of the 2015 Telemedicine Law. Although my screen says Mary Divani, my name is Zoe Hills. I am with the Great Plains Telehealth Resource and Assistance Center, for short GpTRAC. We are a federally designated telehealth resource center that serves a 6-state area, including Minnesota, Iowa, Nebraska, North Dakota, South Dakota, and Wisconsin. GpTRAC provides guidance to healthcare providers, facilities, and organizations that are just beginning their telehealth programs, and also those who are looking to add or expand existing telehealth-related services. Our speaker today is Maureen Ideker. I know Maureen for many years. In fact, I know Maureen since my day one when I started with telehealth 14 years ago, and she's one of my mentors. Maureen is one of Minnesota's and the Midwest pioneers in telehealth. She is the System Director of Telehealth for Essentia Health, and she has been instrumental in developing over 30 rural originating telehealth sites across Minnesota, Wisconsin, and North Dakota, and more than 25 outreach services. She's actively involved with public policy related to telehealth and provided testimony to influence the 2015 telemedicine parity laws in both Minnesota and North Dakota. Maureen also is the co-chair for the North Dakota HIMSS Telehealth Task Force. She was named the Rural Health Hero last year for Minnesota by the Minnesota Rural Health Association due to her long-time commitment to rural health initiatives in her work with telehealth. She currently assists Minnesota's e-health efforts by her participation on the following boards: Minnesota Commissioner of Health's e-health advisory committee, Governor Mark Dayton's broadband task force, and also she represents Minnesota on the GpTRAC Program Advisory Council. And now, without any further delay, I would like to introduce you to Maureen Ideker. Maureen?
Well, thank you, Zoe. And thanks, Becky, for helping us get the Zoom program webinar set up for today. Zoe, it's always a pleasure to work with you at GpTRAC and the good work that you do. I often ask Zoe, well, what kind of questions are you getting lately that come into GpTRAC? And so it's always fun to talk about that. Greetings from Essentia Health. Today I'm at my office at the Holy Trinity Hospital, Essentia Health in Graceville. I want to just start by providing some acknowledgement to the people who helped with this bill, along with many of us out in the telemedicine Minnesota audience. The Minnesota Hospital Association worked to pass the Parity Act, and the Minnesota Rural Health Association also did. So I don't know how many of you have ever provided testimony for things at the legislature, but it was quite an experience both here and in North Dakota. But we were happy we got both the Parity Acts passed, and today we're talking about the Minnesota Telemedicine Law. So like Becky said, I'll be presenting for about 30 minutes, and then we will have questions at the end, so we want to give you plenty of time for your questions. The presentation format that I'm going to be using today is kind of a repetitive format. We'll talk about the summary that GpTRAC prepared, and it's a nice summary. That's part of your PowerPoint slides that will be available to you today. Then we'll actually kind of review again what the Minnesota Telemedicine Law says, and it's Article 9 in the Minnesota State Statutes. Then we'll drill down a little bit in terms of what does Minnesota Medical Assistance, how do they interpret the law, and we'll talk about that. And then we'll look at a particular piece that has to do with an assurance statement for telemedicine, and also then the documentation requirements that are new requirements under Minnesota Medical Assistance. And then we'll have the question and answer part. So the Minnesota Telehealth Parity Legislation Overview was prepared by GpTRAC, and basically the new law went into effect for medical assistance for Medicaid in Minnesota on January 1st of 2016, and it will go into effect for commercial plans on January 1st of 17. What this law requires is that there is an equality of coverage, and that's why it's called parity, an equality of coverage and payment of services for either to be the same, whether it's provided by in-person or telemedicine. It limits the eligible providers to those licensed healthcare providers able to deliver the service within their established scope of practice without direct supervision. So in this law, it doesn't open up additional licenses or additional ways of providing services. It's just a traditional, if they're eligible to provide licensed healthcare services and bill for them in person, they can also do that through telemedicine. The parity legislation, this is an important part that I want to go over with you. The statute itself defined exactly who can be covered, who the licensed healthcare providers are that can be covered. So let's go over this. And it can be found in the state statute, but you need these details in order to look at it. So MDs, physician assistant, chiropractors, nurses. Now under nurses, it's not only the advanced practice nurses, but it's nurses who are certified and licensed to provide services such as diabetic educator, the certified diabetic educator nurse, the certified wound and ostomy care nurse. So if they're eligible to bill, in person, they are eligible to bill under telehealth. Speech language pathologists, that was a new ad. Optometrists, another new ad. Dietitians and nutritionists, that they had privileges before. OT and occupational therapy assistants, the PT and the physical therapy assistant, athletic trainers, psychologists, doulas. Now, for those of you that don't know what a doula is a birth coach, a pregnancy and birth coach. Marriage and family counselors, licensed professional counseling, social work, alcohol and drug counselors, dentistry, and podiatry. Now, this is an expanded list of eligible providers, and I had under Medicaid there, and I'm not real sure why that's on there. This is the way the law reads, is with these providers. Now, the providers that are not on there, you will notice that pharmacists, respiratory therapists, and genetic counselors are not listed under the law. The law also includes additional budget dollars to cover what was the proposed newly eligible providers and expenses under this new law. And regarding these, we'll talk some more about the providers. But for sure, any questions that you have, be sure and jot them down so we can answer them. Okay. The GpTRAC overview, the originating site fee, more commonly called the Q3014 facility fee, will not be covered. We were not able to keep that in the bill. The legislators had a hard time understanding what that particular fee was, and we just couldn't keep it in there. In a couple of years, we probably will go back and try to get it put back in, but for now, the facility fee goes to the wayside. It will not be paid. And as of May 5th, 2015, as soon as the bill came out, Minnesota Medical Assistants quit paying it. The overview, the telehealth visit does not require an initial in-person visit prior to seeing a patient using telemedicine. So there was discussion of that. You know, could a person be seen for an initial consult via telemedicine? And the answer is yes, they can be seen for an initial consult by telemedicine. There does not have to be an existing relationship. The rural and or health professional shortage service area restrictions have been removed. Services can be provided to all areas of the state, even downtown Minneapolis or any metropolitan statistical area. There is no restriction for geographics. The site of service location restriction has also been removed. This is probably the most, the biggest change with the law. A patient can access services from their home, an apartment, place of work, nursing home, hospital, clinic. It doesn't have to be a licensed healthcare facility where the patient can be. So they can be in the comfort of their own home, which we refer to as direct to consumer in telehealth. We'll talk a little bit more on that when we talk about Minnesota Medical Assistants. The telemedicine, as those of us in telehealth like to say, it's real-time, two-way interactive audio-visual communications using secure video conferencing and store and forward technology that facilitates the assessment, diagnosis, consultation, treatment, education, and care management of a patient's care. Now, that being said, telephone, email, and fax communication between providers is not included in the definition of telehealth. Under medical assistance, telephone, email, and fax are excluded from the definition of telehealth. Commercial payers, email and fax between providers and patients are also excluded. Here it says it's currently unclear if telephone only to the patient is included, but it's my understanding it is not included. And also one thing that, it does say email. So when we're talking about text, texting between provider and patient, that is also not included under telehealth. The level of coverage for remote monitoring types of services is currently a little unclear. Minnesota Medical Assistants has clarified it, but our commercial payers will, they'll need to be clarifying it as well. The legislation does not prohibit its use and may allow it under care management, but that is really yet to be determined. Medicaid continues to limit telehealth, telemedicine services to no more than 3 visits per week. And the bill authorized the Commissioner of Health to establish criteria for patient safety and documentation to ensure the safety and efficacy of telemedicine services. And we'll talk a little bit more about that under Minnesota Medical Assistants. Now we have I'm moving on to a duplicate now, where we'll be repeating some things, although, I'm just going to more briefly cover the actual Article 9, which is the actual legislation itself. So the first part that we covered was the GpTRAC summary or overview. Now we're actually looking at the legislation, the law itself, called Article 9. And here it says under 62A.67, short title, this section may be cited as the Minnesota Telemedicine Act. It goes into effect January 1st of 2016. Definitions. And there we see some definitions. Distant site means a site at which a licensed healthcare provider is located. There are additional definitions, and I didn't put them in here. They are in the law if you do want to review them. Under coverage of telemedicine services, so in the law there's a fair amount of detail. So it says about health plans, but it also says that the law does not mean that it shouldn't be construed that telehealth services should be covered when they're not medically necessary. The number 2 there has to do with demonstrating the safety or efficacy, and we'll talk about that, what Minnesota Medical Assistance did with that. And also the Commissioner of Health, and we'll see it under Minnesota Medical Assistance as well, they actually have scripted documentation requirements in order to bill. So that's what that says. The parity under the subdivision 2, the coverage of telemedicine, it just talks about the parity between telemedicine and in-person services. And there it says that if it's a licensed healthcare provider providing the services by telemedicine, it is to be covered. And under reimbursement for telemedicine services, it basically says the same thing. Now the next section I wanted to drill down on, because this section is actually in effect now, and this is for Minnesota Medical Assistance, Physician and Professional Services, Telemedicine, Section 13. Now what this says is just really, it takes and interprets the law for the manual, for the Minnesota Medical Assistance Manual that all of us are familiar with. And this is under the Physician and Professional Services Telemedicine section, Section 13. But now there's different sections in the MHCP, Minnesota Medical Assistance Manual, as many of you know. There's a Physician and Professional Services section, there's a Mental Health section, and there's a Rehab Services section. So, you know, you could go and look under each one of them. They are quite similar, but if you're in that particular field, you probably want to drill down even a little bit further. But this is for physician and professional services, so this is where most of the nurse practitioner, PA, and most of those licensed individuals are falling under professional services. And here it just says, you know, it covers medically necessary services and consultations delivered by Minnesota licensed healthcare provider in the same way as if it was delivered in person. And here we see that there's a limitation of 3 telemedicine services per enrollee per calendar week, and that telemedicine services are paid at the full allowable rate. Then under B, there we have the commissioner establishing the safety or efficacy of delivering, and we'll talk a little bit more about that. It says the attestation may include that the healthcare provider must document under each occurrence and meet the requirements set forth in the, that's a Minnesota rule. And we'll drill down on that in just a minute. Effective January 1st, it allows payment for telemedicine services. Payment is allowed for interactive audio, video, telecommunications, which permit real-time communication between the distance site physician or practitioner and the recipient. The services must be of sufficient audio and visual fidelity and clarity as to be functionally equivalent to a face-to-face visit. So for instance, if the audio is not working on the video conferencing cart, you know, that's a problem. That is not a billable visit. if the visual fidelity and clarity is not good enough, you know, so that it is equivalent to a face-to-face visit, then that is not a billable visit. So the intention is that it's going to be real-time, same-time, interactive audio and visual. And then telemedicine is defined as the delivery of healthcare services or consultations while the patient is at an originating site and the licensed healthcare provider is at a distant site. Now, eligible providers and recipients. You know, we went through the list that was actually in the law. Now, the ones that you do not see on Minnesota Medical Assistance provider list is you don't see chiropractor, you don't see athletic trainer, and you don't see doula. They decided that they were not going to be covering for those 3 licensed providers. One that you do see on here that the law did not state had to be on there was certified genetic counselors. Why they're putting it that way, the language certified genetic counselor, is because the genetic counselors have a national certification. They don't have a state licensure. They have a national certification. And Minnesota Medical Assistance will be covering genetic counseling. So the ones that are not on there again, athletic trainer, doula, and chiropractor. Eligible recipients, telemedicine coverage applies to Minnesota Medical Assistance recipients in fee-for-service programs. Prepaid health plans may or may not choose to pay for services delivered in this manner. Depends on the wording in the plan. Now, the originating site is the location of the recipient at the time the service is being furnished via telecommunication site. Authorized originating sites are listed below. And so let's take a look at this. Office of a physician or practitioner, well, that's no surprise. Hospital, inpatient or outpatient. Critical access hospital. Rural health clinic or federally qualified health clinic. So those are the same as in the past. Hospital-based or critical access-based renal dialysis center, including satellites. Now that has changed a little bit because previously only not-for-profit renal dialysis centers were eligible for reimbursement. But now they've opened that up. It doesn't matter to Minnesota Medical Assistance whether they are for-profit or not-for-profit. Skilled nursing facilities. The ESRD is the dialysis center. Community mental health center, dental clinics. So that's very new. Residential facilities such as group home and assisted living, which are both new sites. And then the home. Now, Minnesota Medical Assistance decided to put the little, explanation behind there and say a licensed certified healthcare provider may be needed to present or to facilitate the delivery of telemedicine services provided in the home. Now, that doesn't mean that somebody like a homemaker, home health aide, always, or a nurse, a home care nurse, always has to be there. But it does mean that when it is needed, that person is there, okay? So, and I spent much time with the Minnesota Medical Assistance working on these interpretive guidelines, making it, being very clear that the home is an eligible site. The guidelines for, I think the purpose for that, the intent is really for people to get care as soon as they need it, rather than getting too sick, and being sick and just ended up costing more because the illness has progressed so far. The MHCP list of services examples. Now, this is not meant to be an inclusive list. And I had requested even some additional codes and that kind of thing be listed on here. And they just said, it's not meant to be an inclusive list. We're not going to go there. But so just examples. of the codes, CPT codes that are listed here. Consultations, there you have the codes, telehealth consults, emergency department or initial inpatient, and you have the codes there. Office or other outpatient visit, subsequent hospital care services with the limitation of 1 telehealth visit every 30 days per eligible provider. Subsequent nursing facility with the same thing every 30 days. End-stage renal disease related services. Individual and group medical nutrition therapy. That's a big add right there. Individual and group diabetes self-management training with a minimum of 1 hour of in-person instruction for the insulin injection training to be furnished in the initial year. Smoking cessation, they'd like to be seeing more of that being used with telehealth, being conducted over telehealth. Alcohol and substance abuse other than tobacco abuse, and assessment and intervention services. So those are just some examples, not all inclusive, but just some. Minnesota Medical Assistance Modifiers. A modifier of a GT modifier along with the code is used to signal that the visit was conducted via interactive audio and video telecommunications. When reporting a service with a GT modifier, the provider is certifying that they are rendering services to a patient located in an eligible originating site via an interactive audio and visual telecommunication system. And the GQ modifier is the modifier that would be used for asynchronous. Remember, I had mentioned about dermatology. I'm not sure if I did mention that. GQ would be the asynchronous. An example of that is dermatology store and forward, where a picture is taken of the affected site on the skin and sent to the dermatologist for interpretation. The dermatologist does not have any interaction with the patient. It's just sending the photo and the history and so on. And then the dermatologist sends back the diagnosis and recommendations for the plan of care to the referring physician or provider. So that's GQ. Now, indications that are not covered by Minnesota Medical Assistance. We talked some about the text, the text-based, the telephone, faxing, that kind of thing. But electronic connections that are not conducted over a secure encrypted website as specified by the health insurance or HIPAA are not covered. So for instance, just using Skype over the public internet for a visit is not a secure encrypted website that meets the HIPAA regulations. Prescription renewals are not covered. Scheduling a test or appointment is not. Clarification of issues from a previous visit is not. Reporting test results is not covered. Non-clinical communication, communication via telephone, email, or fax, there we see that again. The coverage limitations, there we see the Minnesota Medical Assistance, 3 per week. Payment is not available to providers for sending materials. Now, I've just reviewed the Minnesota Medical Assistance coverage, and that started January 1st of 2016. But now in January 1st of 2017, the commercial payers will start to provide their own interpretations of this law. And so those interpretations are not out yet. Maybe that's something, Zoe, this time next year, maybe we want to talk about that, for our different payers. But each one will have, they are subject to the Minnesota parity law. There's no question about that. But I think just as we've seen with Minnesota Medical Assistance, there's a few little tweaks. There's a few things that may be a little bit different on each one. So one of the things that the Minnesota Medical Assistance is requiring, they have a documentation requirement. As a condition of payment, each occurrence of a telemedicine service must include the following documentation: the type of service provided. So maybe it would be the teledermatology or telepsychology, whatever the service is. teleoncology, for instance. The second dot, the time the service began and the time the service ended. So for instance, when the actual video camera was turned on and when it was turned off would be when the service began and the time ended. Now that is not new for Minnesota medical assistants to ask for service beginning and service ending times. They do that for rehab therapy. And so that has been traditional there, but they brought it over here to telemedicine. The third dot, a description of the provider's basis for determining that telemedicine is an appropriate and effective means for delivering service to the recipient. So each visit needs to have documentation of how it was decided for that patient in that visit that it was appropriate and effective. So was it the referring physician who made that determination? Did the provider make that determination as part of the visit? How was that determination made? So those are just two examples of how it's made. Fourth, the mode of transmission of the telemedicine service, and that's like we talked about, interactive. So is it interactive? Is it store and forward like dermatology? Or is it text-based? Now, if you're doing a text-based visit, you could be documenting on it and everything like that, which is good, but it would not be paid. It wouldn't be a billable service. The location of the originating and the distant site. The location of the originating site is where the patient is. So if they're in their home, if they're in the hospital, so it just needs to be documented. What is it? And the distant site is the clinical provider's billing location. Consultations must meet the criteria defined by CPT, so that's no different than an in-person visit. Now, I attached the provider assurance statement because effective January 1, any provider that is enrolled in Minnesota Care, in Minnesota MA, the Minnesota Healthcare Programs, that is enrolled, that is doing or planning on doing telehealth, needs to have a provider assurance statement sent to Minnesota Department of Human Services. And this is the document that has to be signed, that each enrolled provider has to sign and have on file. Now, if they don't have this on file, this assurance statement, they will not actually be eligible for reimbursement. So for each enrolled provider, they have to have this statement on file, this assurance on file, and there you see they have to have the 5 points, the type of service provided, like I mentioned, the time of service, and so on. Okay, so if you haven't done that, if your providers have not done that, that needs to be completed. And you can click on the URL and their manual and so on and get that. I did provide an example of a documentation example because what we did at Essentia, we just put some drop-down boxes, for instance. And so for one of them, a description of the provider's basis for determining that telemedicine is an appropriate and effective means for delivering services to the recipient. We just made up a drop-down box. Was it determined by the referring provider? Was the medical record reviewed? Was the patient interviewed in order to determine it? Was it defined by policy and procedure documents? Those are four that our providers will choose from. The mode of transmission of the telemedicine service, interactive video conference, store and forward, or text-based. So that's meeting the Commissioner of Health's request for safety and for documentation. Okay. I did give you some references and resource links so that you actually will have the GpTRAC, the summary that we've given, and also the actual revisor minnesota.gov, which has the actual statute. And then the Minnesota Medical Assistants, Minnesota Healthcare Providers Manual, Telemedicine and Physician and Professional Services that we reviewed. The Minnesota Statute Subdivision 3B, which is the Minnesota Medical Assistance, and the attachments and PowerPoint from our webinar today. And then also my email in case you have some questions. And we're always happy to help. I know Zoe gets lots of questions, and we, you know, if she doesn't know the answer, we talk about them, and so we'll be happy to help with any answers. So Becky, back to you for the question and answer section.
All right. Thank you very much, Maureen. And the questions are starting to pile in already. So let's see. This one's a really interesting. I'm not sure what this user or this person is asking, but is a utilization by service forecast available?
Is it utilization by forecast?
Service forecast. I'm going to ask for more detail.
Yeah. Okay.
Are you allowed to have an addendum to the note with, quote unquote, the time the service began and the time the service ended?
Yes. Now that would be fine to do. The example that I showed you was we used a drop-down box. But you know, for some documentation, a drop-down box isn't going to have your real answer in there. You're going to have to add an addendum. So no, I think that's fine. The time the service began and the time the service ended is really, you know, I think they're just looking for, you know, when did the camera start and, you know, when did it end? Mm-hmm. Okay, so I think you could put an addendum in there. I think any kind of documentation like that would be fine.
Okay. Next question. Do you think commercial providers will cover pharmacists and certified genetic counselors since they are not listed in the law?
Well, commercial payers we're going to have to see. Now, I can tell you a little bit about the pharmacist piece from the reaction at the legislature. Pharmacist was one that I felt very strongly should be in there. But because of some experience across the nation with that has to do with the day after pills that are connected with abortion, for instance, they decided pharmacists were not going to be covered in the law, and that's where it came from. It came from, you know, a pro-life movement that there wasn't even any discussion of it. It was just you know, a very little discussion of it. I do think that probably commercial payers will look at that, each one of them, and make a decision for themselves, because medication therapy management, for instance, opioid tapering, all of that is done by pharmacists along with the physicians. So it's a very important service, and so I'm hoping that they will you know, that they will each one take a look at it and cover the pharmacists. But right now the law says they wouldn't have to. Certified genetic counselors, because they are a nationally certified provider and not Minnesota licensed, they under the law do not have to be covered. So if commercial providers do take it and cover it, I think that would be the better part of, you know, what should be done. But the law does not state that they have to be covered. So we'll have to really watch it. But I would advocate with your providers, with your commercial providers, for coverage of both of those, because it doesn't make sense not to have them in there, but they're not in the law.
Okay. Can already credentialed providers sign the MHCP assurance statement without going through the full credentialing process?
Yes, absolutely they can. This MHCP assurance statement is a standalone document, and anyone that is doing telehealth already should just go ahead and get it signed, get it sent in, and it doesn't affect the full credentialing process at all. It is just a it goes in as part of their enrollment is the way I would say it. So it just go ahead and get it sent in. Nothing else has to be done.
Okay. Here's a clarifying question on the originating site. And that I thought it was very strange. So the question is, originating site is not reimbursable, correct? And why did
That's
they
correct.
do
That's correct. The originating site is where we talked about the facility fee. The facility fee is the Q3014 code, and we have, over the years, for 20 years, we've used the facility fee code. It doesn't pay a lot, but it's the only, one of the only telemedicine reimbursements that rural sites get. But you are correct. As of the new law, originating site is not reimbursable. Now, Minnesota Medical Assistance is already not paying the facility fee, the Q3014 code, but commercial payers are still paying it. And I think that's one of those things as they interpret their rules, some of them may pay it, may decide, well, let's just keep paying it, but they don't have to under the law.
What was the discussion on that? I just find that strange.
The discussion, it was very hard in the legislature. It was very hard to get the senators and representatives to really understand what that facility fee was. It kind of ended up that they thought that there was some kind of a sliding fee, but that's not it. But, the bill had tremendous support overall, but did not have support for that facility fee, and we had to take the bigger win and go with it. Yeah.
That's interesting. Okay. Someone's looking for an inclusive list of all services covered. The list that I have in the presentation is the list in the Minnesota Medical Assistance, the MHCP interpretive guidelines. Now, if you look under rehab, you'll find additional examples. If you look under mental health, you'll find additional examples. But those were just meant to be examples, and there is not an inclusive list. Any service that is provided, that's covered in person, that is, that makes sense to cover via telehealth, is covered. It has to be covered. That's the parity. But there you will not find an inclusive list. Okay, I'm sending a clarifying question on another one. Are Medicaid patients on an inpatient unit subject to the 3 visits per week rule? I
would say yes, but that would be maybe a question for the an interpretation that I'd have to almost look at the mental health guidelines, interpretive guidelines before on that, before I really said for sure on that. But that's the way it sounds to me, is the 3 visits per week. Yes.
How do you credential and determine privileges for MDs to provide this service?
We use at Essentia, we use the same, and this is what I've seen in past places I've done telehealth too, is you use the same privileging and credentialing packet as you do for your other services, and there isn't any difference.
Okay. Please confirm MA pays for asynchronous services like Virtual and Zipnosis.
Okay, MA pays for asynchronous services, just one, and that's teledermatology. They do not pay for text-based services such as Virtual or Zipnosis. They do not pay for that. The bill says they don't have to pay for text-based telehealth services.
Okay. If you are a provider and wanting to provide telemedicine services from one acute hospital to another, is that acceptable?
Yes.
Okay. Let's see. Script renewals are not covered. Are visits that address script renewals covered?
The medication management visit itself would be a billable visit. Okay. Yes. But if it was just a script renewal, like picking up the phone and, you know, saying, I need my prescription renewed, no, that's not covered. But a regular medication management CPT code encounter would be covered.
Okay. My understanding from DHS was that PMAPs, managed care plans, were to cover telemedicine. They indicated their provider manual needed to be updated to reflect this. Do you have any updates?
I think that's part of what I covered under the MHCP portion of my presentation. That is what's being called the interpretive guidelines from Minnesota Medical Assistants. And that would include their PMAPs or managed care plans.
Okay. Answering a question about the originating site fee. We don't need to cover that again. Once agreeing to covering a service line, is there an anticipated annual utilization or utilization rate?
No, not really. Are you meaning once the insurer has agreed to cover a service line, is there an anticipated annual utilization or utilization rate? No. We actually talked about that a fair amount in the legislature. You know, what kind of volumes is this going to mean? If we had genetic counseling, for instance, how much additional volume would that mean? There were questions like that, but there was no restriction on it or, anything like that.
Sure.
There was it was difficult to project what the use of telemedicine will be, with these changes. So, but that was discussed, and that was part of, how they made the decision that it would be covered.
Another question, what is the application to out-of-state providers, like in the state of Iowa?
The Iowa statutes on telemedicine would need to be looked at. Each state is a little bit different. I do not believe that the Iowa telemedicine parity law passed. Zoe, do you know?
No, Maureen. Can you hear me?
Yeah.
No, I don't think it did. We have to check with Fred. I don't think it did.
Yeah. I know in North Dakota, they do have a telemedicine law that hopefully will be in effect in 2017. But Iowa, I don't think there's passed.
Okay. And I guess I thought about that from a different perspective. If a provider is in the state of Iowa wanting to provide services in the state to patients in the state of Minnesota, they have to have a Minnesota license.
Right, and they would need to be privileged and credentialed at the site that they're going to be delivering services for. Yeah, none of that changes. Right, good. Thanks, Becky, for that interp.
Does the provider assurance statement only need to be completed once or annually?
Only once, one time.
And I'm not familiar with this Minnesota rule. So the 16 county rule no longer exists?
I don't know what the 16 county rule is.
Okay, I will ask for.
Okay.
What defines a clinical social worker? I'm trying to figure out if our master social workers will be reimbursed.
It's my understanding under Minnesota Medical Assistance interpretation that the master's degree social workers will be reimbursed. Okay. And they're a clinical social worker. Lots of times we use the LICSW. Under Minnesota Medical Assistance, they have the general social worker category as well as licensed independent. So the masters prepared are all reimbursable, was my understanding.
What is the reason for the time start and time end information per encounter? If the CPT code is not time-based, why do we need this value?
Yes, I think that's a good question. That start time and end time comes from the tradition of the rehab therapists using that information. And I think they added it under their documentation requirements just for a little extra, I'm not sure, information or what. I don't really see that it is very value added. I really don't know. But it was something that they put in there, and I think it's part of their tradition from the therapy departments. That's all I can react to on it.
Okay. Zoe, are you planning to send out the slides?
Yes, I am. I'm planning to send the slides, and I'm planning to send links to the GpTRAC summary and also a link to the recording, because we had a lot of people asking about the recording.
Okay.
I want to send everything at the same time to everybody.
Great. All right. How are organizations adding these services to increase capacity and access for their population as a value add to healthcare management?
Well, I think that there's quite a few organizations that are starting telehealth services and already using them that, are seeing that it's a way to keep people healthier and to provide more specialty services, like, for instance, for people in rural settings. One example of that is one program that we are working with at Essentia relates to medical weight loss. And, with the problem with obesity in our country, we know that this is an area that people will be able to be healthier, if the obesity is decreased. And so that's just one example. Another example of that would be after a patient is dismissed from the hospital, to actually have them be receiving services in their home location, which many times means that their attendance is going to be better, their compliance is going to be better for their appointments, it's going to be less expensive for them to get to their appointments, and so on. So we're seeing that the readmission, it decreases the readmission rates, for just two examples.
Mm-hmm. So really you're seeing this as a value add for population management and chronic care disease.
Right, definitely, and for accountable care organizations and so on, right?
Let's see, I'm going to try and get some people that haven't asked any questions before. MHCP Provider Manual for Mental Health Services instructs providers to use Place of Service 12 when performing a direct-to-consumer telemedicine visit. Patient receives service in the home. The Provider Manual for Physician Services does not provide an instruction on this place of service. Should we use 12?
I'm not familiar with the with these things under billing.
Okay.
The Provider Manual for Physician Services does not provide instruction on the place of service. Yeah, I don't know why it wouldn't be the same.
Okay. Do you think they're going to start covering remote vital sign monitoring?
I had really hoped, and I advocated for the covering of Tele-home monitoring, because I feel very strongly it's such an important area to keep people healthier and keep them out of the hospital, and to keep people independent in their own home. Even with as many arguments as I could put forward, it just didn't get put in there. And I think that we're probably going to see this in the future, but it is not in the law now. Commercial payers, I think there's some room to say, maybe there's some room to, influence your commercial payers that they should be paying this. There is a durable medical equipment code that actually helps to pay for the equipment under Minnesota Medical Assistance. But that has limitations as well. So I just don't see that. It's not in the rule, but I think over the next probably 2 or 3 years, I just think we're going to need to use it.
Okay. Yeah, because I kind of thought that's where they were going with covering services in the home as the location. Okay, so we have currently answered 25 questions. We have 6 minutes left, and we still have 12 questions on the board. So I'm going to ask Maureen and Zoe, I've got a question about, is it possible to get the Q&As in a document? They can't write fast enough to get all the answers. I will be sending you guys all of the Q&As, so if you want to talk about that, when you send out the slides and everything else, about trying to also include a Q&A document, that might be something to consider.
I think sounds like a very good idea. Yeah.
Yes, Becky, were you saying that I should look at the questions and see if there's a couple to answer yet? Is that what you were saying?
Yes, because we're not going to get to all of these. There's one here in particular I do want to see your, and I can add to it if you don't have a thought on this. Is Minnesota the national leader in telehealth use and telehealth legislation? And how many other types of states have this legislation?
Minnesota is catching up with about 30 other states. We certainly were not the leader. And Zoe, go ahead.
I think Minnesota was the 28th state.
28th, okay.
Yep. I think.
Yeah. But we are definitely probably leading in terms of like genetic counseling and some of those things. But Montana, Washington, Oregon, California, some of those states were the forerunners, and Alaska.
Well, I want to add to this. I don't think Minnesota is the leader, although I wish we were. Maureen and I have been working on this for how many years now? Other states, they're far ahead from us, but I think Minnesota is catching up because every health system in Minnesota is doing something versus a couple of years ago, not everybody was doing it.
Mm-hmm.
Right.
Here's a follow-up question about that 16 county thing. Per Medicare, a rural health professional shortage area located either outside a metropolitan statistical area or in a rural census tract, or a county outside of an MSA. In Minnesota, the 16 metro counties are included in this restriction.
This bill for Minnesota medical assistants and Minnesota commercial payers does not, will not, that won't apply to Minnesota medical assistants or Minnesota commercial payers because they do not care where the patient is located. It can be a metropolitan statistical area or not. It doesn't matter. And I see one question here. Are there state or public examples of the telemedicine policies and procedures required by the provider assurance statement? Not that I have seen. There are guidelines, there's textbooks and so on telemedicine policies and procedures, but nothing that is a public example of that I know of. On the American Telemedicine Association website, there would be some examples perhaps. Can these policies and procedures be general for all types of telemedicine services, or do they need to be more detailed by type of provider service or patient location? The way that Essentia has set up their policies and procedures is that we have it by service. So for instance, like teledermatology has procedures, teleallergy has procedures, and so on. So, but each location, we haven't set that up by location because there's probably not that much difference between locations. Each location would have to kind of take a look at that themselves. But I do not know of any public examples of these policies and procedures required by the provider assurance statement.
Here's one, again, about the patient's home. If the originating site is the patient's home and the patient's accessing the provider via secure application, will MA pay?
Yes, MA will pay direct to the patient's home.
Okay.
They have clarified that with me very, very, very clearly.
Okay. And can 2 same-day services be delivered and billed for via telemedicine to MA, doctor visit and therapy visit?
I would say yes. I think the restriction is a weekly, 3 per week.
Okay.
And I see a utilization rate or forecast for new telehealth services. I've seen this question a couple times. There was no actuarial report that was used for projecting the increased cost for this bill. There was discussion of it, and there was, of course, a dollars and cents put on it, but it wasn't actually an actuarial report forecasted.
Okay. It is 2 o'clock. Well, I'm sorry, 1 o'clock for you guys. Do you want to pick 1 or 2 more questions, Maureen?
What happens if you don't have one of the elements of the assurance form in place? Do you just not initial that line item? I think that the expectation from the Commissioner of Health is that you would have those elements in place. I think the expectation is that all of those would be in place. But, I mean, you could try it, but I would say you might get it sent back. I don't know that, though. That's a good question. There was a question about genetic counseling sessions. Was there any forecast for that in the Minnesota Medical Assistance Program? No, there was no forecasting. It's just they're included for coverage. Do you have any insight into social work visits being covered, but that the National Social Work Professional Standards preclude remote treatment? Oh, I don't know that. A few counties in Minnesota believe that their social worker visits must be in person due to professional standards. Yeah, I don't know the details on those kinds of things. It's a good question, and I think we're going to see, you know, just like we saw with the Minnesota medical statutes, you know, they needed to be updated a little bit. Zoe and I were just working on that a couple weeks ago again. You know, that the Minnesota statutes for medicine needed to be updated. So I think there is going to be quite a bit of that kind of work going on in the next couple of years. Those are the only, oh, let's see, there is legislation waiting for federal approval for chemical dependency telemedicine services to be covered. With the new January 1st, 2016 telemedicine law, if a CD provider is eligible according to this law, then CD telemedicine would fall into the new law and can be provided. That's a very good question, because it's my understanding that under the CD laws, they defer to federal law. And therefore, there are some parts of CD services that are not covered. So that one, it really needs some drilling down on that. And the federal legislation is awaiting, and it's not approved at this point for certain parts of the services, like prescribing for methadone, for instance. Okay, that's all the questions that I see.
Okay. All right, we will, like we mentioned before, we'll get, Zoe will send out the slides and documentation, everything. We'll have a list of the questions and try and do some Q&A in writing as well. But I want to thank you for joining us today. And Zoe, did you have anything else?
I just want to thank everybody for attending. I got a couple of emails from attendees that they said that was the best webinar they attended so far. So I was very happy. Thank you, Maureen and Becky. Becky, we didn't introduce you. The person who is doing the technology part, she's the executive director, I don't know the exact title of Becky, I'm sorry, for the Upper Midwest Telehealth Resource Center in Indiana. And she's an expert in this technology. So she actually didn't volunteer. I asked her to volunteer to help us the technology for today's webinar. So thank you, Becky, very, very much. We had no glitches to my knowledge. Everything was very smooth. I'm very excited. And I will be sending to everybody that registered, although they didn't participate today, because I have their emails and their names, the copy of the presentation, the link for the recording once I get it from Becky. Right, Becky?
Yep.
And the summary, the GpTRAC summary, and I don't think what was the other one, Maureen, a couple other things.
Just the PowerPoint, I think. But
the PowerPoint, yeah. Okay, great.
Okay.
Thank you, everybody.
Yeah. Bye now.
Thank you.
Okay, bye-bye. Have a nice day.